Okay, so the next topic that we're going to move to is minimal residual disease. So we've spoken briefly about it. But what is minimal residual disease? And this iceberg analogy is used a lot. It's pretty easy to see an iceberg above the water level, and that's active myeloma, and we're trying to get rid of that. And so we're trying to get rid of the, obviously, crab symptoms, if you will. That's an easy picking. Get rid of the hypercalcemia, renal failure, anemia, and bone disease. But is that enough? Well, you can get to PR, partial response, near complete response as shown there, and get down to stringent complete response. But even when you've gotten down there, and it looks like the iceberg, you've really chopped off a lot of that, you see there's still a huge amount of tumor left below the iceberg. And to truly get to what we are all here to do is get to a cure, we need to get rid of all of that burden of disease. And so getting to a cure requires two parts. One is getting better diagnostic testing, and the other is better therapeutics. So if we don't have the better diagnostic testing, we'll never be able to achieve that. So there are efforts now to get to these deeper levels of testing, and MRD is really how much myeloma is remaining in the marrow, or as you heard, potentially even in the blood. With novel techniques, I'm sure people would be terribly disappointed to forego marrows, but the future, we think, will be the blood. And that'll especially address the clonal heterogeneity, meaning having it from one pocket versus another pocket, although it won't completely resolve that. So what we're looking for is how sensitive are these tests. We can now detect down to 1 cell in a million. So if you look at this graph, initially at initial diagnosis, there's a lot of tumor, clearly, and on the left is the numbers. If you're a number person, on the right is more just a conversion into our standard myeloma response criteria. So to get to the first level of response, PR requires a 50% reduction, typically in their protein measurements. Near complete response typically means that you've gotten rid of the protein, but maybe that immunofixation, there's still a trace amount of myeloma left, but it can't even be quantified. Complete response is, okay, we don't really see anything by our standard technology. Now you get into minimal residual disease type of testing. You can get into PCR-based testing. There's also flow cytometry-based testing, and those are getting to these MRD negative states. But even those, we still think may not be enough, and obviously we need to see how deep these responses are. But the other part of MRD testing is, remember, it's just a one time point. How sustained is this MRD? Attaining MRD negativity at one time point is great, but you need to sustain that, and that's another important part of the MRD discussion that we don't always talk about. So how can MRD be measured? As I was alluding to, there are efforts being done to look at circulating tumor DNA, looking at circulating tumor cells. This is also being done in solid tumors. And also, the other important part I have down there is that, remember, when we're doing a bone marrow biopsy, that's a random sample. So often people may ask, if I had a bone fracture, or if I have a plasmacytoma, and we know it's myeloma, why do we need to do the bone marrow from the hip? And that's because typically we want to look in the uninvolved area where we don't know of any overt lesion, but what is the plasma cell burden in the uninvolved area? And by definition, if it's more than 10%, that's myeloma. But when we're talking about MRD, it's very important to remember that when you're sampling the marrow, if PET scan or MRI is showing disease, and you're not going for that particular spot that's seen on the imaging, you may end up doing the marrow, you may end up getting an MRD negative test, but you will have missed the big picture, which is that there's still potentially disease left. So, and there are studies, particularly from Arkansas again, that perhaps 10 to 20% of patients who get MRD negativity from the marrow may have disease left elsewhere in the bone. So if somebody's really going to have MRD negative testing, it may be reasonable to repeat the radiologic imaging first, because if that's positive, why do the marrow? Wouldn't change your management. And if the imaging is negative, then proceed with the marrow for the confirmatory MRD. So does this really matter in 2017? This is from the IFM study that you heard about from Dr. Cho earlier, which showed that in the RVD arm, patients who had MRD positivity did worse than the MRD negativity. And then in the transplant arm, same thing, MRD positivity versus negativity. So you could argue, well, if I'd gotten MRD negativity with RVD, why do I need a transplant? And the problem is that this is, remember, when you initially starting to treat patients, you don't know which group of patients or people are going to end up in. You have the benefit of response here. So at new diagnosis, when you do RVD and transplant, yes, you may have response to both, but the question is, what is the higher likelihood of getting an MRD negativity? Is it with just RVD or with transplant? And it looks like with transplant, we saw higher rates of MRD negativity. Although if you do get MRD negativity with RVD alone, that may be very meaningful as well. And so the key question, obviously, is can we predict this even before going on to treatments? Not yet. But what we've seen, in the meta-analysis means many of the studies are put together. And so there were 14 studies that were analyzed, including 5 that had transplant, 10 that was included maintenance. And consistently, we see that MRD negativity correlated with both the duration of remission, so-called progression-free survival, and overall survival, which is how long people lived. But the important thing is that only one study showed predictive value in unfavorable cytogenetics. What does that mean? In some of our other cancers, like CML or APML, where there's a characteristic PCR test, and if you're negative, it means the same for everybody. What we're seeing in myeloma is, yet again, it's a heterogeneous disease. MRD negativity in a high-risk patient may not mean the same thing as an MRD negativity in a low-risk patient. And so this is really important to consider as we're starting to make treatment decisions. Yes, it's good to go deeper and deeper, but does it mean the same thing in different studies? So to summarize, how would we consider MRD today in practice? The benefits, it's going to give us prognostic information. MRD negativity correlates with clinical benefit. Particularly for, it's easy, what will be the use of this? Because in heavily pretreated patients, what's going to be most important is overall survival and progression-free survival. But because newly diagnosed patients are living so long, how are we going to know if, say, RVD versus RVD with an antibody, whether the antibody is doing any better? Because if they're newly diagnosed patients are living really long time, it'll take forever for that study to tell us whether one regimen is better than the other. And it's in those kinds of settings where maybe the MRD negativity can be used as a surrogate endpoint. So you don't have to follow patients for 15 years or 10 years to get your results, but you can at least have a preliminary signal at 1 year, 2 years, whether this novel regimen is doing better than what we expect. So I think the earlier you go, newly diagnosed, maintenance, the more important there may be a role for MRD. The later you go, the less there's a role, because who cares about MRD in heavily pretreated patients if the relapse is happening quickly? So the other issue, though, so those are the benefits. What are the downsides of MRD? First is that there are a lot of technological issues. So the sensitivity of tests really differs. For example, when you do flow cytometry, which is one of the methods, basically you take the liquid from the bone marrow, the aspirate, and then you run it through a machine which attaches fluorochromes, or basically light-emitting particles, to different proteins. And then they're able to pull out the cells that look like myeloma and see if there's evidence of myeloma. The problem is there's so many issues to doing that test. So, for example, how good was that aspirate? Was it mainly blood, or did they get a lot of marrow? How quickly did it get to the lab that's testing it? How many cells did the lab run? How many proteins did they test? When you put all of those technological issues, it is quite possible that a patient could have a marrow from 2 sides or even from the same side and sent to different labs, and one lab is going to say this is MRD positive and the other one's going to be negative. And that's a big problem for us in medicine when there's lack of standardization, because we all want to go to a place with MRD such that, for example, with hemoglobin, there's no way that our hospitals are going to give you one person's hemoglobin is 8 and another one's 12. That's just not done because there's a lot of lab standardization to do that. Until we get to that level of reproducibility, this can't be used routinely because we won't know what we're doing. Second issue, and that pertains to standardization. Third issue is can we apply MRD testing to each patient? Flow cytometry can be done with everybody because you're just looking for myeloma cells based on their expression. The next-gen sequencing, or the genetic-based, PCR-based testing, requires 2 samples from each patient. The sample that you're testing for MRD, say after chemo, transplant, and maybe before maintenance, so you need that marrow sample, but that marrow sample is going to have very little myeloma, and you need the baseline marrow, when there was a lot of myeloma, to determine whether you can find the clone that can be then looked for in the repeat marrow. So not every patient will necessarily be valuable with that technology. And as we talked about, the utility and high-risk question. So the questions I'll pose to my panel now are, currently, can MRD guide risk-adapted therapy? So are you adding therapy to MRD-positive patients?
So, wow, this is really one of those things you ask 6 hematologists and you get 10 answers. And this is one that you really have to work with your doc about. So, in my mind, it really is only applicable to the people who achieve a complete remission or possibly who's on antibody therapy and get a VGPR. So when it gets really down low and the proteins no longer are good at testing for myeloma, then we look, is there something better in the marrow? I think we can all agree that it could be used as a way to monitor the results of a clinical trial, that the more people that get the deeper remission, that get MRD negative on one arm versus another, is probably going to be a better thing. I think we can all agree on that. What we can't agree on, and this is not just us, is we had a whole big meeting, a myeloma meeting last weekend with 100 myeloma docs, and there was shouting, there was apple throwing, it was a whole thing going on. What we can agree is if you don't achieve MRD negativity, when do you say, okay, with this regimen, enough's enough and let's switch? Or, for the people who achieve MRD negativity, okay, is that enough? Can we stop? So those are the two big questions. Somebody asked me in the break, should they still be on maintenance therapy? And we talked a little bit, and I found out that this person, and this is kind of how this is the only clinical decision that's easy for me with MRD, is when I have a patient that gets their therapy and they're MRD negative, and we're deciding on continuing therapy like maintenance therapy or et cetera. When we talk about side effects, and I say, what side effects you're on? And they say, gosh, I'm having a hard time doing this or that. I have cramps. I have all this. And we have that report that says you're MRD negative. We say, why don't we take a break? It's a lot easier to take the break when that paper says MRD negative, rather than saying, well, let's reduce a little and see how you do. And that's literally the only clinical decision that I've made with MRD.
Yeah, I agree with Tom. The data from trials such as the IFM trial are applicable to newly diagnosed patients who are going on induction and consolidation therapy. So using that MRD assessment at the restaging visit to guide your next steps makes sense because we have data that suggests that the outcome is predicted by the MRD status. And everything else, I think, really needs to be done in the context of a clinical trial because we need to know whether we can use that kind of data in the relapse setting for second transplants, for immunologic therapies versus drug therapies. These are all open questions. And I think it's important that we do this type of research so that we understand if we can use MRD as a surrogate for disease-free or overall survival in clinical trials, and also if we can use them to make clinical decisions. But at this point, I don't think it's generally applicable.
The only other thing that I'll add, and you guys might know Dr. Barloghi, you may go by him around the clinic, is he was probably the loudest guy at the meeting, saying, I have plenty of patients that are 10-year survivors, 15-year survivors, and they would be MRD positive. Why are we doing so much about this kind of thing? So I just want to tell all of you, it really is a good goal to achieve MRD negativity, but it's not, essential to be a 10-year survivor, even a 15-year survivor. You can be that kind of survivor and not achieve MRD negativity.
So I was going to add, I kind of, to echo that sentiment, when we were teaching medical students, we always say don't order a test unless it's going to change your management, right? Because if you're going to do the test and look at it and say, okay, that's nice, but what am I doing with it? Why are we doing it? And the problem was there's a major data gap. As you heard, there's a lot of technological issues. But let's just, and this came up actually just this week. I was at a community hospital and I was asked by one of the doctors, so we did a marrow and this patient's MRD test was negative. Can we stop the therapy? But my first question was, what was the details of the technique? Because if that patient's therapy is stopped and is being done by a suboptimal lab or technique, you're actually doing a disservice to the patient, right? So that's why this still needs to be in clinical trials. I think the first place, though, we would think about, I think the most interesting thing about stopping therapy would be in somebody who's low risk and MRD negative, right? Because there, at least, if this patient biologically is low risk and they've had sustained MRD negativity, that would be the population that we could see. Are we over-treating? And can they do well without treatment? But I think for high-risk patients, it's still very premature. And so I think we clearly need more data. And so I agree with, in the setting of clinical trials, it's definitely a very important pursuit.